This is a recorded lecture for Chapter 16 of Anatomy and Physiology, second semester, blood. The blood composition is really a mixture of several things. It's a mixture of a fluid, connective tissue, which is composed of plasma, which is the clear component of the blood proper. There's also many formed elements within the blood. They include erythrocytes, other names for a different name for red blood cells, or RBCs is the short version of that, or leukocytes, which is also white blood cells and often called WBCs, and then platelets, which are the cell fragments, if you will, that help to create a clotting system, and we'll talk more about clotting later in the lecture. We look at blood, we measure the blood by the percent of volume of red blood cells compared to the rest of the blood, and we call that the hematocrit. So the percent of blood, the blood component compared to the fluid and the white cells, the measure of that is called an hematocrit. In males, about 47% of their blood is really made up of red blood cells, plus or minus 5%, and in females it's about 42%, plus or minus 5%. Here's how we kind of look at that. We draw some blood through a phlebotomy, put the blood in a tube. We centrifuge the blood down. When we centrifuge the blood down, the density of the red blood cells is greater than the density of the white cells, which is greater than the density of the plasma. So that 55% of the whole blood is really made up of that least density, lesser density plasma. About 1% is made up of the white cells and the platelets, which are in that buffy coat. You'll see that. And then finally the erythrocytes, which are located in the bottom of the tube. And so this gives us a feeling that what we've just done is really the hematocrit we talked about. So we have the liquid portion, and then from the buffy coat down, we have the formed elements, if you will, the elements that make up other than the liquid portion of the blood proper. The blood proper is a sticky, opaque fluid. Its color can be scarlet to dark red. It has a 7.35 to 7.45 pH, and the temperature is body temperature, 38 degrees centigrade. The blood makes up about 8% of our body weight, and the average volume of blood in our body is 5 to 6 liters for males and about 4 to 5 liters for females. The functions of blood: first of all, it's a distribution of oxygen and nutrients to all the body cells. It helps to remove metabolic waste to the lungs and kidneys for elimination. And it helps to transfer or to move, if you will, hormones from endocrine organs to their target organs. It also helps to regulate body temperature by absorbing and distributing heat. It has some pH buffers that help to normalize the pH of the body, and it provides an adequate fluid volume in the circulatory system so that there can be a movement of blood. Blood provides us protection against blood loss. We have plasma proteins and platelets that have clots in them. Clotting proteins, if you will, help to clot the blood so that when we have an opening, then hopefully we don't bleed to death. The blood also helps us with infection. It helps to transmit antibodies, as we learned in the previous chapter from the type B lymphocytes. It helps to mobilize complement proteins, which help to our general response to an infection, and it also helps to mobilize WBCs, white blood cells, which defend against foreign invaders, and usually those are the phagocytic cells, the macrophages, and of course the neutrophils. The blood plasma, we're just talking about the liquid component, is really 90% water. The proteins that are in that are mostly produced by the liver. 60% of the proteins within that blood plasma are albumin, 36% are globulins, and 4% are fibrinogens. The nitrogenous byproducts of metabolism, lactic acid, urea, and creatinine are also located in the blood plasma, as well as nutrients, glucose, carbohydrates, and amino acids. And of course electrolytes, the sodium, potassium, calcium, chloride, and bicarb are located bicarbonate are located within the blood plasma, and the respiratory gases, the oxygen, which we bring in, and the CO2, which we expel, and we already talked about the hormones previously. We talk about the formed elements, we really have a lot to talk about because only the white blood cells are really complete cells. That is that white blood cells have nuclei, and they have their complete components. For red blood cells, at least the red blood cells that are in the circulatory system, not in the bone marrow, have no nuclei. Now red blood cells start out with nuclei, They have a nucleus when they start out, organelles, but as they mature, those go away because they have a in life, and their only job, if you will, as they move into the circulatory system is really to transfer oxygen and CO2 and the other little things we'll talk about. The platelets are really fragments of cells. They start out as large cells, megakaryocytes actually, and then they break apart, and those broken fragments, if you will, become platelets that are circulated throughout the circulatory system. Most formed elements survive in the bloodstream for only a few days. Now, it says only a few days. When I say a few days, red blood cells will survive 30 to 60 days, actually. And most blood cells originate in the bone marrow, and they do not divide. So most blood cells actually come out of the bone marrow proper, and they don't divide. So what do you want to take away? Only white blood cells are complete cells. Red blood cells have no nuclei organelles in the circulating system. Platelets are really not whole cells, they're fragments of cells. And most of the formed elements only last a few days and are a little different for each one. And blood cells originate in the bone marrow, and they don't divide as they go on. They don't go through mitosis or anything like that. So as we look at this, we're looking at a microscope view of a blood smear, a right stain, and you see the little dots here are platelets. They're just little cell fragments. These are neutrophils, and neutrophils are multinucleated. They have many nuclei in them, and we'll talk more about that later. And then there's a lymphocyte, which is a cell that has a very large nucleus and a very little bit of cytoplasm. We also have monocytes, and monocytes tend to have a U-shaped nucleus with kind of this little bit of cytoplasm. We talk about erythrocytes. They're really biconcave discs with anucleate, without nucleuses, that essentially have no organelles. When we say biconcave, they're kind of like a Cheerio with the center filled in. That's kind of what they look like. They're filled with hemoglobin, and that's their primary function is for gas transport. That includes the movement of CO2 and the movement of oxygen. They contain the plasma membrane protein spectin and other proteins which provide flexibility so they can change shape as they move throughout the circulatory system. And they're the major factor contributing to the viscosity, the thickness of blood. Viscosity is a term we use to look at thickness of blood. Like oil has viscosity. Oil that is 50 grade oil is much thicker than 10 grade oil. And so blood has a viscosity also. This is a look, we're looking at a red blood cell. You can see the top part does look like a Cheerio, with the center parts that are filled in. This is a cut through the center, if you will, through the center of a red blood cell, and you can see that biconcave look, that almost where it kind of indents on both sides, and it looks just, like I said, a Cheerio is a very good way to look at that. Erythrocytes have structural characteristics which contribute to their ability to transport gas. The biconcave shape gives a huge surface area relative to the volume of the cell itself. The cell is 97% hemoglobin, not counting the water. It has no mitochondria. ATP production is anaerobic. There's no oxygen generated for the ATP because oxygen is a transported material, not a functional material. And it's a superb example of complementary of structure and function. It really does exactly what it's supposed to do. It's the perfect answer for the transport of oxygen and CO2. And clearly, red blood cells, RBCs, are dedicated to respiratory gas transport, or respiratory, you can say it either way. Hemoglobin binds reversibly with oxygen and CO2, helping to transport. We talk about erythrocyte function, we have to talk about the hemoglobin structure, which is a protein, which is made up of a protein globin, which is 2 alpha and 2 beta chains, and a heme pigment bonded to each globin chain. The iron atom in each heme can bind to one oxygen molecule, so there's an iron atom in each heme that binds to that one molecule of oxygen. Each hemoglobin molecule can transport then 4 oxygen molecules. What we're seeing here is that hemoglobin consists of a globin, 2 alpha and 2 beta polypeptides chains, and then 4 heme groups. And so you can see where the oxygen can be transported right there. And you get that feeling there's the iron, and you can see how that can be transported. The iron-containing heme element right there. And it's the iron that allows us to do that. Hemoglobin, big H, little b, allows us to do oxygen loading in the lungs. Oxygen comes into the bloodstream via the lungs and attaches to the blood, and it changes the hemoglobin into oxyhemoglobin. That is oxygen attached to the hemoglobin. And it's very red when it does that. The endpoint is that it shows that ruby red color that we see in, what we think we see in blood most of the time. As oxygen is unloaded in the tissues, we see that there's no more oxygen, it's gone, and it produces a deoxyhemoglobin, so that there's no hemoglobin at all. There's other names for that, but it's a reduced hemoglobin, so it's dark red. So with oxygen, it's bright red as it gets oxygen in the lungs, and as it unloads that oxygen in the tissues, it becomes deoxyhemoglobin. CO2 loads in the tissues, and so you'll see that as the oxygen is released in the tissues, carbon dioxide is loaded back into the hemoglobin from the tissues, and it produces what's called a carbinohemoglobin, also called carboxyhemoglobin, which carries about 20% of the CO2 in the blood. So oxygen comes in from the lungs. It attaches to the hemoglobin, making oxyhemoglobin. The hemoglobin is then transferred via the circulatory system to tissues. The oxygen is unloaded, producing deoxyhemoglobin for just a split second. And then CO2 is loaded onto that same hemoglobin, and that produces carbinohemoglobin, or carboxyhemoglobin is another term for that. And the carbon dioxide is carried back to the lungs, where it's released into the atmosphere as we breathe out, and guess what? We breathe in again, and we reproduce that oxyhemoglobin. It's a perfect cycle. When we talk about the blood cells, we have to talk about hematopoiesis, which is the medical term for blood cell formation. And also see hemopoiesis. You'll see both those terms. They mean the same thing. It occurs in the red bone marrow of the axial skeleton, in the girdles and the proximal epiphyses of the humerus and the femur. We already talked about that. We talked about the skeletal system back when we did that in the first semester. Hematopoiesis starts out with hemocytoblasts. These are hemopoietic stem cells. They give rise to all the formed elements. They all start out as hemocytoblasts, and they give rise to those formed elements. These are the stem cells, or the beginning cells, or the embryonic cells of the system. Hormones and growth factors push the cell toward a specific pathway of a blood cell development, and the new blood cells enter the blood sinusoids, as we call them. Erythropoiesis is the red blood cell production. That's the more specific answer. More specific, we're talking about red blood cells. Hemopoiesis or hematopoiesis is really talking about all of the blood cells. So erythropoiesis, red blood cell formation. Hematoblast, hemocytoblast, you'll hear that, is transformed into what's called a proerythroblast. So hemocytoblast is transformed to a proerythroblast, and this is where the red blood cells actually have nuclei. The proerythroblasts develop into early erythroblasts, again, still have nuclei. The phases of development of erythropoiesis, there's ribosome synthesis. The hemoglobin begins to accumulate within the red blood cell. There's an injection, a breakdown, if you will, of the nucleus, the formation of what are called reticulocytes. Reticulocytes are really red blood cells with a remnants, if you will, of the nucleus still in them. It's not a function. It's like the shell of the nucleus without the contents. It's like the skeleton of the nucleus, so to speak. And the reticulocytes then become mature erythrocytes because that skeleton also disappears. So here's the process. We start with a stem cell, a hemocytoblast. It becomes a committed cell to the red blood cell line. It becomes a proerythroblast. The development pathway begins, and in phase 1, the ribosome synthesis occurs, and you see an early erythroblast, and yes, there's a nucleus still. You see a late erythroblast, and yes, there's a nucleus. We see that early normoblast, there's a nucleus remaining, and then, of course, we see that expelling of the contents of the nucleus, and then a reticulocyte. Reticulocyte still has remnants of that of what's left of the shell of that nucleus. That's really the center of the nucleus, and then finally it develops into a full mature erythrocyte without any kind of organelle or without any kind of nucleus. Regulation of erythropoiesis, too many red blood cells can lead to tissue hypoxia because it kind of causes sludge in the circulatory system, so they can't move the red blood cells, and so oxygen can't happen. too few red blood cells lead to tissue hypoxia because there's not enough red blood cells to carry the oxygen to the tissue. Too many red blood cells increases the blood viscosity and also causes hypoxia. And the reason it does that is because the red blood cells get sludged up and they can't really move the oxygen down to the tissues. So there has to be a balance between red blood cell production and the destruction of the red blood cells. So the cells have to have a normal dynamic process that allows them to live and die in a special sequence. That's done by hormonal controls and adequate supplies of iron, amino acids, and B vitamins. Hormonal control of erythropoiesis is really managed by erythropoietin, which is released by the kidneys in response to hypoxia. So erythropoietin is a hormone that is directly related to the kidneys, and it's released when the oxygen content of the blood goes below a certain level. The erythropoietin is a direct stimulus for erythropoiesis. So this causes erythropoiesis as a stimulation, and this is released based on a reduction of oxygen in the blood system. Some causes of hypoxia are hemorrhage or increased red blood cell production, which reduces the red blood cells in circulation and reduces our ability to carry oxygen. There could be an insufficient amount of hemoglobin. We have the right amount of red blood cells, but the hemoglobin, we don't have enough hemoglobin. So that could come from the fact that we either don't have very good iron, or we don't take enough iron in our bodies, or that the hemoglobin is ineffective. Sometimes we have enough hemoglobin, but it's not the right kind of hemoglobin. And then it could be because we don't have enough oxygen coming into our system. If you get to higher altitudes, there's less oxygen available, and so we have less oxygen that comes into our systems, and you can become hypoxic. Hypoxic meaning not enough oxygen based on all these things working except not enough oxygen available or ability to take it in. We talk about effects of erythropoiesis. There's more rapid whenever we have hormonal control. The EPO, erythropoietin, causes a more rapid maturation of those committed bone marrow cells, those red blood cells, and it increases the circulatory reticulocyte count in 1 to 2 days. So what happens is the bone marrow starts to push out the less mature red blood cells, and some of those are reticulocytes. They have the ability to move oxygen. They're not as good, they're not mature, but they still have some of those remnants, those nuclear remnants that we talked about, the nuclei remnants. Testosterone also enhances erythropoietin production, resulting in higher red blood cell counts in males. And this talks about how that process works, that feedback mechanism. The stimulus is hypoxia, a low blood oxygen carrying ability due to decreased red blood cell volume, decreased amount of hemoglobin, or decreased availability of oxygen. That causes the kidney and liver to a small extent to release erythropoietin, and really mostly that is the kidney. Erythropoietin stimulates the red bone marrow to produce, if you will, and enhanced erythropoiesis increases the red blood cell count. That red blood cell count is released into the system. Those red blood cells are released into the system, and those oxygen carrying ability of the blood increases, and then we alter that hypoxia. There's some dietary requirements for adequate erythropoiesis. We have nutrients. We need our blood cells are made up of amino acids, some lipid and carbohydrates, iron for sure, and stored in hemoglobin. Most of our iron is stored in hemoglobin, 65% of it, the liver, the spleen, and bone marrow. Iron is stored in cells as ferritin and what's called hemosiderin. It's transported loosely bound to the protein transferrin. We also need vitamin B12 and folic acid, which are necessary for DNA synthesis for cell division. So if we don't have those, we can have a type of anemia. The lifespan of the average red blood cell is 100 to 120 days. Old red blood cells become fragile and hemoglobin begins to degenerate, and macrophages engulf those dying red blood cells primarily in the spleen. So macrophages eat the red blood cells primarily in the spleen. The heme and the globin, after the destruction of the red blood cell occurs, are separated. Iron is salvaged for reuse, and the heme is degraded to the yellow pigment bilirubin. The liver secretes bilirubin in bile into the intestines. The degraded pigment leaves the body in feces as what's called stercobilin or stercobilinogen. The globin is metabolized back into amino acids. And so the body reuses all the parts it needs to. It takes the iron and salvages for use. It takes the heme of hemoglobin, breaks it down into pigment bilirubin. Bilirubin secretes that bilirubin back into the bile in the liver. into the intestines. The degraded pigment leaves the body as stercobilin or stercobilinogen. You'll hear both those terms. And globin is metabolized in the amino acids. As we look at that process, we see that low oxygen levels in blood stimulate kidneys to produce erythropoietin. We see erythropoietin levels rise in the blood. We see erythropoietin, the necessary raw materials in the blood, promote erythropoiesis of the bone marrow. We see new erythrocytes in the bloodstream, and they function for about 120 days. The aged and damaged blood cells are engulfed by macrophages of the liver, spleen, and bone marrow, and the hemoglobin is broken down. That primarily happens probably through the majority of the time in the spleen proper. The other organs do it to a lesser degree, unless the person has had a splenectomy because we injured the spleen, and then the other organs take over and do that same job. What happens then is the raw materials are made available to blood for the erythrocytes we talked about. And then finally, the bilirubin is extruded via the liver, through bile into the intestines, and then it goes out to the feces via stercobilin or stercobilinogen. We can have erythrocyte disorders where the erythrocytes aren't able to accomplish the function they're supposed to. We call those anemia. Anemia, by definition, is blood that has an abnormally low ability to carry oxygen. So anemia isn't defined as we have low red blood cells or low iron or whatever. It's the function of our oxygen carrying capacity. It's a sign rather than a disease. Anemia is not a disease. There's lots of things that cause anemia. It's a result of lots of diseases, but it's a sign, it's not a disease. And the blood O2 levels cannot support normal metabolism if we're anemic. There's something going on. And it can be accompanied by fatigue or paleness or shortness of breath and chills. So all those things are symptoms of that anemia. Causes of anemia could be insufficient erythrocytes. That could be caused from hemorrhagic anemia, so we lose a lot of blood, acute or chronic loss of blood. So we have loss of blood, so we don't have enough red blood cells carrying the blood that we need. We got hemolytic anemia. That's where the red blood cells rupture prematurely, don't last very long, and the bone marrow can't keep up with the breakdown of red blood cells, so the cells break apart and die faster than they are functional. We have aplastic anemia, where there's destruction or inhibition of the red bone marrow, so the red bone marrow isn't able to keep up with the destruction because there's something wrong with the bone marrow proper. We can have causes of anemia from low hemoglobin content, that is iron deficiency anemia, the secondary result of hemorrhagic anemia, or it can be caused from inadequate intake of iron-containing foods, or it can be caused from impaired iron absorption. So it could be we're losing a lot of blood, and the blood's being lost out, so we can't reuse the iron, and we can't take it in fast enough. We're not taking enough iron-containing foods. We don't need enough liver and spinach and those kind of things. And then we have an impaired iron absorption. That means we're just not being able to use the iron. Pernicious anemia. We get cause of anemia is pernicious anemia. That means we're not taking in enough vitamin B12. That means it could be a lack of an intrinsic factor needed to help us absorb that B12. So we're either not getting B12 or we're not able to absorb the B12. And we usually treat that with intramuscular injections of B12 or an application of what's called Nascobal. That's how we treat a pernicious anemia. We can also have abnormal hemoglobins. There are thalassaemias, and not for this class, but it's called thalassemia minor and thalassemia major. And that means there's an absence or faulty globin chain. That means the hemoglobin is not the right hemoglobin. It's a different kind of hemoglobin. Red blood cells are thin and delicate, and they don't really have a very good hemoglobin or a functional hemoglobin. We can have sickle cell anemias. That's where we have a dysfunctional hemoglobin. That means it's caused by defective gene codes, and it causes an abnormal hemoglobin called HbS, hemoglobin S. It causes the red blood cells to become sickle-shaped or bizarre-shaped under stress or in low oxygen situations. Person goes up in a plane, and their red blood cells start to sickle, and that means that the red blood cells aren't functioning very well. It clogs up all of the capillaries, and so the blood cells aren't able to move, and this blood isn't able to move, and it causes death of tissue. It's a terrible disease. So the normal erythrocyte has a normal hemoglobin amino acid sequence in the beta chain. You can see that right here, and that shows that. In sickled erythrocytes, and that's what they look like, they're very weird. This is actually an electron microscopy of that. You can see that the order has changed, and there's a dysfunctional amino acid or an abnormal amino acid within the chain. The chain has changed, so it's no longer functional. We can also have polycythemia, which is an excess of red blood cells that increase the blood viscosity. There are two kinds of polycythemia. One is called polycythemia vera, or P. vera, and it's a type of bone marrow cancer that causes red blood cells to just be produced willy-nilly, and everything else is not produced. So what happens is we have lots and lots of red blood cells to the point where the viscosity of the blood gets very, very thick. We have very little plasma and a lot more red blood cells that kind of sludges up our circulatory system. And number one. And number two is that we don't produce enough white blood cells, so our immune system doesn't work as well. We can have a secondary polycythemia when there's less oxygen is available at high altitude, or when erythropoietin production increases. And then we have blood doping. Blood doping is what some sports people have done. And what they do is they remove their own blood before a race, 30 days or so before a race. And just before the race starts, they inject that blood back into their system so they have many more red blood cells than they need, which increases their oxygen carrying capacity and evidently makes them more functional or more efficient. Now we're going to talk about the white blood cells, or leukocytes, and they make up about 1% of the total blood volume. They can leave capillaries via that diapedesis, as we've talked about when we were talking about the immune system. They can move through tissue spaces by ambioid motion and positive chemotaxis. Ambioid means they kind of look like amoebas. They kind of move by pseudopodal movement. And positive chemotaxis, that is, they respond to certain chemicals that are released in certain areas of the body. Leukocytosis is any white blood cell count over 11,000 per cubic millimeter. And it's our normal response to infection, whether that be bacterial or viral invasion. As you can see, we looked at formed elements. We have platelets, we have leukocytes and erythrocytes, and leukocytes are really a very small amount. So we have a differential. We take those leukocytes and we look at those and we have different kinds of leukocytes. We have granulocytes and agranulocytes. And granulocytes are white blood cells that when they're stained in a right stain look like they have little granules in their cytoplasm. Agranulocytes are without granules, and so they're just named based on what we see in our microscope. The granulocytes in the total leukocyte count includes neutrophils, which provide over about 50 to 70% of the white blood cells available. We have eosinophils, which normally are about 2 or 4% of the average white blood cell count, and basophils, which are about 0.5 to 1% of the white blood cell count. The lymphocytes are about 25 to 45% of the white blood cell count, and monocytes are about 3 to 8% of the total white blood cell count. So all total, we're talking about that white blood cell count, normal being 4,800 to 10,800. That's the content we're talking about. We talk about the white blood cell types. We'll see those in a minute. Granulocytes, I said, include neutrophils, eosinophils, and basophils. And we call them granulocytes because they have cytoplasmic granules which stain specifically with a right stain. They are larger, the granulocytes are larger and shorter lived than red blood cells, and they have lobed nuclei. And we'll talk about that in a minute. And they are phagocytic. That's kind of interesting to know. The neutrophils are the most numerous of the white blood cells. They have what are called polymorphonuclear nuclei. That means the nucleuses are not just round. They can be multi-lobed or U-shaped or horseshoe-shaped. And so they're called polymorphonuclear leukocytes, or PMNs. They have 5 fine granules to take up both acetic and basic dyes, and it gives that cytoplasm kind of a lilac color, kind of a cross between that blue and that pink. The granules contain hydrolytic enzymes or defensins, and they're very phagocytic. They have their bacteria slayers, and if you remember back in the immune system, neutrophils and macrophages are the phagocytic cells of the body. Eosinophils are beautiful actually under a microscope. After they're stained, they're red to pink staining. They are bilobed, meaning they can have 1 or 2 nucleuses. They're red to crimson in color. They're acidophilic. They have coarse lysosomal-like granules. They tend to digest parasitic worms that are too large to be phagocytized. So they attack, if you will, parasitic worms or parasites of the body. They also are modulators of our immune response. Basophils are the rest of the white blood cells, WBCs. They are large, and they stain kind of purple to purplish black. They're basophilic granules, and their granules contain a histamine. Histamine is an inflammatory chemical that acts as a vasodilator to enlarge the blood vessels and attracts other white blood cells to inflamed sites. So it actually helps the inflammatory response. And they're functionally similar to mast cells, and mast cells are also histamine-containing granules. These are the three cells we just talked about, the granulocytes underneath the microscope. You can see a neutrophil. You can see that multicolored granules, the kind of pink and blue kind of colors. You see the nucleus is kind of bizarre shaped. It's multi-lobed. What you're seeing here is really, they're all attached by little strands, but it's multi-lobed nucleus. When we look at eosinophils, you can see the very pink to red color in the granules, and it's kind of a U-shaped or a horseshoe-shaped nucleus most of the time. This is a basophil, and you see those really dark purple to blue granules. It's bilobed nucleus. It's purple with black cytoplasmic granules, and you can see that these are very different when you're looking at them under a microscope. There's two agranulocytes. That includes the lymphocytes and the monocytes, and they don't have any visible cytoplasmic granules. They usually have a spherical or a kidney-shaped, U-shaped, if you will, nucleus. The lymphocytes have a dark purple circular nucleus with a very thin rim of blue cytoplasm. Not very much cytoplasm is seen. And they're mostly located in lymphoid tissue, and a few circulate in the bloodstream. And they're very crucial to immunity, as we talked about the B and T lymphocytes. We know that there's the T and the B lymphocytes. The T cells act against virus-infected cells primarily and tumor cells, and the B cells give rise to plasma cells and, of course, to memory cells, which produce antibodies. So we know that already. The monocytes are the largest leukocytes circulating in our system. They have a very abundant pale blue cytoplasm. They have a dark purple staining U or kidney-shaped nucleus. The monocytes can leave the circulation in their tissues, and they can differentiate into macrophages. And so macrophages and monocytes are the same thing. A monocyte is what we call the cell in the bloodstream. A macrophage is what we call in tissue. A macrophage, like the neutrophils, are actively phagocytic. They're crucial against viruses and intracellular bacteria parasites and chronic infections. And they also help to activate lymphocytes to mount an immune response, like we talked about before. So here's the lymphocyte. We see that really large purple nuclei and not very much cytoplasm, kind of dark cytoplasm, as opposed to a monocyte where we see that kind of U-shaped or horseshoe-shaped nucleus, and we see a lot of cytoplasm around it, almost almost a fluorescent blue cytoplasm. And this is the table that's in your book, which goes through each of those cells and talks about how they do their production, and I'd like you to do that. Leukopoiesis is the production of white blood cells, and it's stimulated by chemical messengers from the bone marrow and other mature white blood cells. We know from our previous chapters that interleukins include IL-1 and IL-2, and they've also colony-stimulating factors, or CSF, which are named for the white blood cell type to stimulate. In other words, they have granulocytic CSF, which stimulates granulocytes, and non-granulocytic CSF, which stimulates, guess what, agranulocytes. All leukocytes originate from hemocytoblasts, just like the red blood cells did as those stem cells. This takes you through that process of the differentiation as it goes down. It's important to take a look at that in your book. We also have leukocyte disorders we talk about, and that includes leukopenia. And penia means abnormally low. So leukopenia is abnormally low white cells. That can be drug-induced, or drugs that actually reduce the number of white cells. We also can have leukemias, which is an exacerbation or an abnormally high number of white blood cells. Cancerous conditions involving the white blood cells can cause leukemias. It is a leukemia. Leukemia is a cancer, and the leukemia is named according to the abnormal white blood cell clone involved. Myelocytic leukemia involves myeloblasts. Lymphocytic leukemia involves lymphocytes. Acute leukemia involves blast-type cells and primarily affects children overall. Chronic leukemia is more prevalent in older people. So acute leukemia is more common in children. Chronic leukemia is more prevalent in the oldsters. In leukemia, bone marrow totally is occupied with those cancer leukocytes, and so the bone marrow only really focuses on producing that one type of cell and doesn't produce the other types of cells, which means it's not producing other white blood cells or other red blood cells, which means we have a decreased oxygen carrying capacity, number one, and if the leukemia is producing monocytes, for instance, and not lymphocytes, then our immune system goes away. The immature non-functional WBCs are in the bloodstream and they don't work. There's lots of them, but they don't work. And so death is caused by internal hemorrhage and overwhelming infections because our ability to respond to our immune, we're becoming immune incompetent. And then we have treatments include radiation, anti-leukemic drugs, and stem cell transplants from other people to sort of repopulate the bone marrow. Platelets, another formed element in our blood, is really formed from fragments of what are called megakaryocytes, the original real cells that they come from. The megakaryocytes break apart, and the fragments start to circulate within our bloodstream. Formation is regulated by thrombopoietin and blue staining outer region. They're kind of purple granules. The granules contain serotonin, calcium enzymes, ADP, and a platelet-derived growth factor, PDGF. Platelets form a temporary platelet plug that helps to seal breaks in our blood vessels when we get an injury. Circulating platelets are kept inactive and mobile by NO and prostacyclin and endothelial cells of blood vessels. So a hemoblast becomes a megakaryocyte, becomes a promegakaryocyte, becomes a megakaryoblast becomes a promegakaryocyte. A megakaryocyte then breaks apart and becomes that platelet, as we talked about. We talk about hemostasis, or the stabilization of blood movement. There's a fast series of reactions for stopping bleeding. There's vascular spasm, which closes off the blood vessel in the blood vessel so bleeding stops, a platelet plug formation, and then coagulation, which is really blood clotting. We talk about vascular spasm. That is really vasoconstriction or constriction of blood vessels, damaged blood vessels. Some of the triggers are direct injury, or chemicals released by the endothelial cells in the platelets, or just the pain reflex itself. So all of those can cause that vascular spasm, which sort of pinches off the end of the blood vessel. Then we have platelet plug formation, and there's a positive feedback cycle that occurs. It's one of the two major positive feedback cycles of the body, the other one being the oxytocin that we talked about, and we talked about the endocrine system. What happens at the positive feedback cycle of platelet blood formation is at the site of the blood vessel injury, platelets stick to the exposed collagen fibers with the help of a von Willebrand factor, we'll talk about that, and a plasma protein. They swell, they become spiked and sticky, and they release chemical messengers. Those include ADP, which causes more platelets to stick and release their ADP, and then serotonin and thromboxane, A2, which enhances vascular spasm and creates more platelet aggregation. What you're seeing here in step 1, you see the vascular spasm, a smooth muscle contracts, causing vasoconstriction. In step 2, we're seeing a platelet plug formation. Injury to the lining of the vessel exposes collagen fibers, and platelets adhere to that. The platelets release chemicals, that ADP we talked about, that makes nearby platelets sticky, and platelet plug formation. Then we also have the coagulation. The fibrin forms a mesh that traps the red blood cells platelets, which forms that fibrin clot. Coagulation is a set of reactions in which the blood is transformed from a liquid to a gel-like substance, and that helps to reinforce that platelet plug with the fibrin threads. There are 3 phases of coagulation. The prothrombin activator is formed, and there are 2 pathways that it's formed within the intrinsic and extrinsic pathways. The prothrombin is converted to thrombin, and then that thrombin catalyzes the joining of fibrinogen, to form a fibrin mesh. This takes the intrinsic and the extrinsic pathways. In the intrinsic pathways, the vessel endothelium ruptures, exposing the underlying tissues. The platelets cling, and their surfaces provide sites for mobilization factors. Factor 12 becomes factor 12 12A. 9 becomes factor 9A. Factor 9 with calcium causes factor 9, and factor 7A from the extrinsic system activates factor 9A, and you can see that PF3 is released by aggregated platelets. 8th factor becomes factor 8A. Factor 9A and factor 8A form a complex. Factor 10 becomes factor 10A, and with calcium and those PFs we talked about, PF3s, and with the help of factor 5 and 5A, we activate the prothrombin factor. In the extrinsic system, the tissue cell trauma exposes the blood to tissue factor. That tissue factor, which with calcium and that factor 7 and 7A, then becomes TF and the tissue factor and factor AA complex comes over and combines. So you can see that both these systems are very important, and we have anticoagulants, blood medications that stop the coagulation of blood. We have systems that work on. We have blood types or anticoagulants that work here and anticoagulants that work here. This talks about that phases also. We have prothrombin factor, the prothrombin 2 and 2 becomes 2A. Fibrinogen soluble becomes fibrinogen insoluble polymer, and ultimately becomes cross-link fiber mesh thanks to the addition of both thrombin 2A, fibrinogen 1 soluble, calcium, and factor 8 changing to factor 8A. Coagulation phase 1, as we relook at that, are two pathways the prothrombin activator. That can be initiated by either the intrinsic or extrinsic pathway, and usually it's both. It can be triggered by tissue-damaging events. It involves a series of coagulants. Those are precursors, if you will, to the coagulation process itself, and each pathway cascades towards that ultimate factor 10. Factor 10 complexes with calcium and the PF3s, and factor 5 to form that prothrombin activator that we need at the very end. The intrinsic pathway is triggered by negatively charged surfaces like activated platelets or collagen or glass. It uses factors present within the blood, the intrinsic system. The extrinsic pathway is triggered by exposure to tissue factor or factor 3, an extrinsic factor. It bypasses several steps of the intrinsic pathway, so it's faster, if you will, than the intrinsic pathway. Prothrombin in the coagulation phase 2, prothrombin activator catalyzes the transformation of prothrombin to the active enzyme thrombin. In phase 3, the thrombin converts soluble fibrinogen into filamen, and converts soluble fibrinogen into fibrin. The fibrin strands form the structural basis of clot. The fibrin causes plasma to become a gel-like trap for all the foreign elements of the circulating blood system. Thrombin, with the activation of calcium, activates factor 8, which cross-links with the fibrin and strengthens and stabilizes the clot. And this is a nice electron microscopy of what that looks like. This is a really great picture. And you can see those fibrin, web-like fibrin pieces, and you can see the red blood cells, and you can't see the little platelets that are there also. The clot actually goes to retraction at about 30 minutes to an hour, and that's where actin and myosin, the platelets contract, and the platelets pull on the fibrin strands, which squeezes the serum from the clot and makes it a tighter clot. There's a clot repair process where the platelet-derived growth factor, that's PDGF, stimulates the division of smooth muscle cells and fibroblasts to rebuild, if you will, the blood vessel wall. Vascular endothelial growth factor, VEGF, stimulates endothelial cells to multiply and restore that endothelial lining. Fibrinolysis begins in about 2 days, and that means the breakdown of fibrin. The plasminogen in the clot is converted to plasmin by tissue plasminogen activator, or TPA. Factor 8 and thrombin. Plasmin is a fibrin digesting enzyme, so that's how it works. Factors limiting clot growth or formation are two homeostatic mechanisms to prevent clots from becoming large. There's a There's swift removal and dilution of clotting factors and inhibition of the activated clotting factors. So if there's limiting clot growth or formation, it can be as a result of a swift removal and dilution of clotting factors or inhibition of activated clotting factors. The inhibition of clotting factors, most thrombin is bound to fibrin threads and prevented from acting elsewhere. Antithrombin 3 and protein C and heparin inactivate thrombin and other procoagulants. Heparin, which is an anticoagulant, also inhibits thrombin activity. And so heparin actually works to, we use heparin as an anticoagulant, and it inhibits thrombin activity. Factor 3 and undesirable clotting could also be effective platelet adhesion. It can be prevented by smooth endothelial lining of the blood vessels, antithrombic substances like nitric oxide, and prostacyclin secreted by endothelial cells, vitamin E quinine, which acts as a potent anticoagulant, and also aspirin, St. John's wort, ginkgo biloba are all they all prevent platelet adhesions. They all can extend the bleeding time of blood. There are disorders of hemostasis, which include thromboembolic disorders, which end up with an undesirable clot formation. You can also have bleeding disorders, which are abnormalities that actually prevent clot formation. In the thromboembolic conditions, the thrombus, the clot that develops and persists in an unbroken blood vessel, may block circulation, leading to tissue death. So it doesn't work well. An embolus, excuse me, an embolus is a thrombus freely floating in the bloodstream. Now, a thrombus can be an embolus, but an embolus can be more things than a thrombus. So an embolus is anything that floats in the bloodstream that can block blood vessels. A thrombus is a blood clot. And so if it's in one place, it's a thrombus. If it gets loosened and starts to circulate, it becomes an embolus. Now you can also have fat and all sorts of things that can be floating in the blood. The embolus causes pulmonary emboli, which impair the ability, moves to the lungs, and impairs the ability of the body to obtain oxygen because it blocks up clogs up those capillaries in the lungs. It can also cause blockages in the blood vessels in the brain, causing strokes. And so that's how that works. It says thromboembolic conditions can be prevented by aspirin, and as I said, aspirin is an antiprostaglandin that inhibits thromboxane A2. Can be blocked by heparin. Heparin is that anticoagulant we talked about, which is used clinically for pre- and postoperative cardiac care. It prevents clotting. And warfarin, which is the other name for that is Coumadin, is used for those prone to atrial fibrillation or chronic clotting problems, and all those can block the clotting process. Some of the diseases that occur that are the abnormal things that occur are disseminated intravascular coagulation, DIC. It causes a widespread clotting which blocks the intake of blood vessels, so the body just suddenly starts clotting everywhere. Severe bleeding occurs because we've used up all our clotting material all throughout the body. It's most common in pregnancy, septicemia, which is an infection of the body, or incompatible blood transfusions. DIC can cause a widespread clotting everywhere. Then we also can have bleeding disorders, thrombocytopenia, which is a deficient number of circulating platelets. So we don't have enough platelets. PHGY, if we have thrombocytopenia, PHGY, a little pinpoint bleeding in the tissue appear due to spontaneous widespread hemorrhage throughout our body. And it's due to suppression or destruction of the bone marrow, which also kills off, obviously, the platelets or due to malignancy or radiation. The platelet count has to be greater than 50,000, and so a platelet count of less than 50,000 per cubic millimeter is diagnostic, and it has to be treated with transfusion of concentrated platelets from other donors. Platelet disorders can come from impaired liver function because there are inability to synthesize the procoagulants that help to create platelets. Causes include vitamin K deficiency, hepatitis, and cirrhosis, which hepatitis and cirrhosis are infections of the liver. Liver disease can also prevent the liver from producing bile, impairing fat, and vitamin K reabsorption or absorption. We can have hemophilias, which include several similar hereditary bleeding disorders. We have hemophilia A, it's the most common type, 70% of the cases, and it's due to a deficiency or either an absence or a deficiency in factor VIII. So you can have factor VIII and it doesn't work, or you can have you don't have factor VIII. You can have hemophilia B, which is deficiency in factor IX. And you can have hemophilia C, which is a milder version, but it's a deficiency in factor XI. The symptoms can include prolonged bleeding, especially into joint cavities, so you can get what are called hemarthrosis. The treatment is with plasma transfusions or the injection of the missing factors. Transfusions or whole blood transfusions are often used when there's blood loss is substantial, and packed cells, where the plasma has been removed, are used to restore the oxygen carrying capacity of blood. The transfusion of incompatible blood can be fatal and often is. When we talk about human blood groups, we're really talking about the different red blood cell membranes which bear those different glycoprotein antigens which differentiate the blood types in human beings. They can be perceived as if they're transferred to the wrong person as a foreign glycoprotein. And they're kind of unique to each individual. We have groups of them, but they're kind of unique to the individual. And promoters of agglutination are called agglutinins. So the absence of each antigen is used to classify the blood cells, and so we'll talk about what that means. Humans have 30 varieties of naturally occurring red blood cell antigens, but the antigens of the ABO and RH blood groupings cause vigorous transfusion reactions. ABO stands for blood type A, blood type B, blood type O. Other blood groups, MNS, Duffy, Kell, and Lewis, are usually weak agglutinogens, or so they cause weak agglutination, if you will. We talk about the ABO group. We have 4 potential blood types. We have type A, type B, type AB, and type O. And the blood types are based on the presence or absence of 2 agglutinins or 2 antigens on each red blood cell, that being A or B on the surface. The blood may contain anti-A or anti-B antibodies, agglutinins, that act against transfused red blood cells, ABO antigens that are not present. So let me go back and look at that. Type A blood has A antigens on the red blood cell and produces anti-B antibodies. So it has anti-B antibodies because that way if the B antigens are transfused into the person, they would kill them. Type B red blood cells have B antigens. That is, B antigens are protein on the outer layer, the outer membrane of the red blood cell, and they produce anti-A. So they could kill any A blood that's transfused. AB blood has both A and B antigens on the cell wall, if you will, and they produce no antibodies. So they produce anti-A, they would kill themselves. They produce anti-B, they would kill themselves. Blood type O has no antigens whatsoever. O stands for 0 antigens. But it produces anti-A and anti-B because it doesn't have those antigens. So that's the way we actually, I'll show you later, how we identify what type we're talking about. So based on the presence or absence of 2 agglutinins, as is antigens A and B on the surface of red blood cells. Blood may contain anti-A and anti-B antibodies that act against transfused red blood cells with ABO antigens not normally present. So anti-A and anti-B form in the blood at about 2 months of age. So we have antibodies. It's one of the few times in the immune system where we actually have naturally occurring antibodies, anti-A and anti-B. Only time it happens. So as we look through this, it's really important that you get a kind of a feel for what we're talking about. What we have is A, B, B, A, and O. And what you're seeing here is it tells you the incidence of when that occurs. You can see that we talk about AB blood, we have A and B antigens on our red blood cells, but no antibodies. On type B blood, we have B antigens on our red blood cells, and we make anti-A antibodies. We have an A-type blood, we have A antigens on our red blood cells, and we make anti-B antibodies. And finally, type O blood, we have no antigens on our red blood cells. We make anti-A and anti-B antibodies. Now, O blood is the universal donor because if you use packed cells, the red blood cells have no antigens for the antibodies of other people to react to. The universal recipient is really AB. AB people, because AB people don't make any antibodies. So you can give them any kind of blood, basically, AB, or O, because they don't make any antibodies against anybody. So we talk about the RH blood groups. So we talked about ABO blood groups. We talk about the RH blood groups. So we take, O positive, R positive, R negative. The negative or positive stands for RH typing. There are 45 different RH agglutinogens, RH factors, that are possible. C, D, and E are the most common, and RH positive indicates the presence of D directly. So RH positiveness or negativeness is included in RH positive. We do not naturally produce anti-RH. So if you're RH negative, you don't naturally produce anti-RH. So whether you're RH positive or RH negative, unless you come in contact with a transfused blood of the opposite blood, you don't produce it. Anti-RH antibodies form if an RH negative individual receives RH positive blood. So unless you're an RH negative and you receive RH positive blood or come in contact to that, then you don't produce any antibodies. And basically, you produce the antibodies the first time. So you have RH negative blood, your body produces RH negative anti-RH. If you get that blood again for some reason, it results in a transfusion reaction. And that is the basis for what's called hemolytic disease in the newborn, or erythroblastosis fetalis. The RH negative mother becomes sensitized when she becomes exposed to the RH positive blood of her body from the baby. And at that point in time, the baby is born, blood is absorbed into her system, and she synthesizes anti-RH antibodies. So the baby's gone. That first baby is fine. And the antibodies cross the placenta, and so that's the first time. The anti-RH antibodies, what happens the second time, so the mother has another RH positive baby, because RH is a IgG antibody and crosses the placenta. That anti-RH antibodies cross the placenta in the second baby and destroy red blood cells of the second RH positive baby. Now, if she has an RH negative baby, the next time, no problem. If she has nothing but RH negative babies from then on, no problem. And so the baby can be treated at pre-birth with transfusion, exchange transfusion after birth. To prevent all that now, which is hemolytic disease in newborn erythroblastosis fetalis is pretty common, we use a substance called RhoGAM, which is a serum which contains an anti-RH which can prevent the RH negative mother from becoming sensitized. So we kind of hide the RH positive blood, or we prevent the mother's ability to react to RH positive blood, so she never develops the antibodies. So let's talk about transfusion reactions, and they occur obviously if there's mismatched blood is transfused. The donor cells are attacked by the recipient's plasma agglutinins, or the antibodies. They agglutinate the blood cells, clog them together, and they clog the blood vessels, small blood vessels, and they rupture and release that free hemoglobin in the bloodstream. The result is that there's a reduced oxygen carrying capacity, and the hemoglobin starts to clog the kidney tubules and eventually causes renal failure. We talk about blood typing. When the serum contains anti-A or anti-B agglutinin added to the blood, agglutination will occur between the agglutinin and the corresponding agglutinin. So what we're talking about is agglutination. Clotting will occur between agglutinin, that being the and the agglutinins. I'll show you again. Positive reactions indicate agglutination. Let's see what that looks like. So if we have AB blood, we have AB antigens, right? But we don't produce any anti-A or anti-B. If we add anti-A and anti-B to AB blood, it will the anti-A antibodies will clot the A and the B antigen of their blood, and that will cause a positive reaction or agglutination. If we have B blood, we have B-type antigens on the blood cell. If we have anti-A to B blood, it won't clot because there's no antigen of A there. If we add anti-B to B-type blood, it'll definitely clot because the anti-A clots with the B antigen. If A-type blood, type blood has A antigens on the cell wall, and if we put anti-A into that, anti-A antibodies, it will clot the A blood, but the anti-B won't clot it. If we take O blood, where there's no antigens, we get an anti-A or anti-B, and it won't clot. And this is the basis for our blood typing, or how we blood type in the laboratory. So let's look at that. So we have type AB blood. Remember that it contains the antigens, agglutinogens, if you will, A and B. And so agglutinates, we had anti-A antibodies to it and anti-B antibodies to it. So we know that that's AB blood. In type A blood, it contains the agglutinogen A, or antigen A, another way to say that. And so when we put anti-A to it, it agglutinates. We put anti-B to it, it doesn't agglutinate. In type B blood, it contains the agglutinogen or antigen B. It agglutinates with type B, so it tells us B-type blood, but the anti-A does not cause agglutination. In type O blood, the O blood cells do not have any agglutinogens on them or antigens on them that are A or B, and it does not agglutinate with either A or B type antibodies. We talk about restoring blood volume. We really need to do that because death can come from shock, which results from low blood volume. And the volume has to be replaced immediately. We do that with lots of ways. We use normal saline. Normal saline means it's isotonic saline. Or we could use multiple electrolyte solutions that mimic plasma electrolyte composition. Ringer's lactate is one of those, and there's lots of others, and normal saline. We have plasma expanders like purified human serum albumin, head of starch, and dextran, which also will expand it. And they mimic the osmotic properties of albumin. They're more expensive, and they can actually cause some complications. So mostly we use normal saline and lactated ringers. Some diagnostic tests we have for red blood, when we look at our blood, we have an hematocrit, which we looked at before, and that's the measurement of the white blood cells, the percentage of white blood cells. We can do blood glucose tests, which tell us the amount of sugar that is in our blood. And we do microscopic examination, which tells us the variation in the morphology, that is the shape and size of red blood cells, and that may help indicate some anemias. We can also do what's called a differential white blood cell count. We can count the different kinds of white blood cells to make sure the percentages are accurate. We can do a prothrombin time and a platelet count, which assesses our ability to clot blood. We can do a SMAC or an SMAC, which is a blood chemistry profile, which checks all the electrolytes and other things in the blood. And we can do a complete blood count, which actually measures our number of blood cells, measures our hemoglobin in the blood, measures our hematocrit, as we talked about before, and lots of other things. So we've talked a lot about the blood, if you will, in Chapter 16. This concludes the recorded lecture for Chapter 16. Thank you.